Welcome to InteropChat, where we break down the latest developments in healthcare interoperability and what it means for healthcare organizations, providers, and patients. I'm Dave Cassel, SVP of Interoperability at Innovaccer, and I'm joined by Jen Blumenthal, Product Director at Milliman Intelliscript, Deven McGraw, Chief Regulatory Officer at Citizen Health, and Dr. Stephen Lane, Chief Medical Officer at Health Gorilla. So it has been a while since this particular band has been together, and a lot has happened since the group of us last spoke. So first of all, the biggest elephant in the room, there's obviously a new administration taking shape, and with that, new directions and new policies from a health IT standpoint. And there certainly are early signals of a shift in how federal agencies may approach health IT. Deven, I'll start with you, and obviously others can jump in here quickly. What's your general sense of the current environment and where the federal government is going under the new administration and what that might mean for the health IT world?
Sure. I think we have still a lot of uncertainty about where health IT policy is going, what's going to happen with ASTP/ONC. This is a particular space where there's more rumor than actual sort of facts on the ground in terms of pronouncements. Back in March, the Department of Health and Human Services did put out a reorganization plan that did a number of things, including moving the Office for Civil Rights into a new Assistant Secretary for Enforcement. So the Office for Civil Rights, which is in charge of all things HIPAA, gets kind of moved, maybe demoted, might be a way to look at it, because they previously were in Office of the Secretary with a direct report to the Secretary. Now they're going to directly report to an Assistant Secretary for Enforcement who reports to the Secretary, so a level down. But ASTP is still ASTP, the Assistant Secretary for Technology Policy. I think a lot of us, I'm frozen a little bit. I think a lot of us assumed that would go away. There's still the Office of the National Coordinator for Health IT, same office that has the certification authority per congressional statute. Lots and lots of rumors about it moving into CMS, but nothing definitive. The office is still being led by Steve Posnack in an acting capacity. Lots of rumors around, is TEFCA going to happen, not happen? We can talk about that, but it still exists. A little bit less information coming out, given still some directives given to agencies around communications with the public. The Health IT Policy Committee has not met in this administration, in this term, and I'm on that. And so the meetings through August have all been canceled. Whether that ever goes anywhere again is an open question. So again, lots of more uncertainty than not. We'll talk a little bit about the request for information that is out there now for public input, issued by both CMS and ASTP/ONC. Some people are saying, that suggests they're going to be combined in the future. Others suggest, no, this is an indication that they're still going to be separate, but working together more closely. You decide. We shall see.
Hey, Deven, can I ask you a follow-up question on that? Because you are on the Health IT Advisory Committee,
thank you.
As I was in the past. And I was this year supposed to be on the Interoperability Standards Work Group, which is a work group of that committee, which met once and then everything was canceled after that. There has been zero communication to the work group members other than the cancellation of the meetings. Have the HITAC members gotten anything more out of them?
No.
Okay.
No. Just cancellation of meetings.
And to your point, Deven, that does seem consistent with the general directive around communication. And I think some of the possibly some of this is in reaction to not only some of the changes that are being made and the work of the Doge group and so forth, but also the experience in the first Trump administration of some frustration on the part of administration officials of folks speaking out of turn from their perspective. So I assume I don't have any insider knowledge, but I assume there's a little bit of concern about that happening again.
Yeah, I mean, I can only say from my experience of having worked for about 10 months in the first Trump administration is that there is, let me see if I can put this in the most politic way, a desire on the part of political appointees to be more in control of the message and operations and programming. So that generally trickles down to the staff as, you're not allowed to talk about anything, act on anything, say anything publicly unless it's been endorsed by a political appointee. And that's always to some degree the case, right? Like elections matter, political appointees set the direction of agencies and offices in the federal government, but there wasn't previously this sort of real dividing line between, sort of career staff and politicals in terms of how things proceeded. So I think it's a little bit different. It's a little bit hard for me to judge because I only had that one experience, but it's kind of par for the course and maybe even stronger and more widespread in terms of politicals run the government and nothing can really happen without their endorsement.
Yeah. Jennifer, Stephen, anything to add on the general topic? Obviously, we have some specific aspects of the new administration that we're going to dive into here.
Well, I think, as Deven said, there's a lot of rumor. You hear from people who are generally well connected and they, tell you a little bit of something. I don't know how valuable it would be for us to spend our time sort of cataloging last week's rumors or from the week before. But I think, as you said, some people interpret them as a direction that will suggest that some of what the agencies have been doing will continue forward, whether it's the ASTP and ONC, being named in official documentation, et cetera. I feel that the progress will be made, but we can get into the details.
I mean, I've basically been operating under the assumption that until they name someone, we won't really have a sense of what is actually going to happen. So the rumors about the ASTP/ONC merging with CMS, that was that's been going on even pre-election. And that didn't matter if it was Democratic or Republican. Then who's being named in that role after Mickey Tripathi? That also has been very interesting to listen to all the rumors on the rumor mill. But whenever people ask me, what do you think's going to happen with policy? I'm like, we have to wait to see who's named, because until somebody's there leading it beyond what Steve Posiak is doing in his current role, everything is just rumors and we have to wait and see.
Yeah, and I agree. We do have some hints as to where some of the early thinking is going, in part from a RFI that CMS and ONC, ASTP have jointly released, and that Deven mentioned in passing in her comments. Based on the RFI, I guess what did you take, Jennifer? I guess your picture is up, so we could start with you. What hints did you take from that document as far as sort of what the line of thinking was and what we might be able to expect?
I think overall, the list of questions from the administration is what do we want to do that is big, and what can we actually get done? I think it's an interesting opportunity. I think everybody should be reading this RFI and responding to it, because it's kind of open-ended. I think it takes influence from some presentations and white papers that came before it, but it's basically a call to be like, what are we doing? What should we be doing? And I was going to ask you guys, I mean, for me, I can't remember when, for Cures Act, for instance, how long before Cures Act was actually published was there an RFI out? Because what's most interesting is what's the turnaround time from responses to actual proposed rulemaking to rules. But that was what I've been thinking about. I think overall, this RFI should fix a lot of the issues that Cures Act couldn't cover in that rule.
You know, what really struck me was the fact that patient needs were right up top. I found that refreshing. Clearly, we've all done a lot of work in the area of individual access to data and understand the importance of that and the challenges that we've faced as an industry. So to see that right up front, I think, bodes well, for that. I mean, I don't think that we can expect to be working on all of the same fronts over the next, years that we have been working on over the past years. But the fact that something that is, I think, near and dear to all of our hearts is front and center on that RFI, that, as I say, bodes well.
I would agree with that. Oh, sorry. Go ahead, Jennifer.
Well, go ahead, Jen.
I was going to say to what Stephen's saying, I think it's an opportunity to kind of address everything that isn't working with FHIR APIs in production for all their use cases. So what are use cases for FHIR APIs? Patient access, which is a 3-legged OAuth workflow. The provider workflow, where it's a 2-legged workflow, and even the backend services workflow, where it's system to system, and applying even the system to system use case more commercially. The other thing is, I think that TEFCA is a big part of the responses that are going to be submitted for this RFI. So when I said it's filling in the gaps from Cures Act, a lot of Cures Act didn't putting it into reality. It has problems. So I'm hoping that the way people respond to this RFI, thinking big, is we're addressing all the issues from all the technology investment that's been happening over the past 10 years. So high tech to Cures Act to whatever this RFI becomes named in rulemaking.
Good. I'm in agreement. I mean, look, you can't change the statute by a regulation, but you sure can change the regulations that have come out. And while there's a lot that's kind of hardwired about the Cures Act, and particularly around information blocking, that the regulations just basically reiterate and maybe flesh out a little bit, it doesn't mean that there's not a lot of room for some different priorities to some degree. It is incredibly encouraging that one of the first things that we see out of the administration on this issue is something that, is clearly embracing interoperability, strongly endorsing patient access. How can we improve it? What should we be doing next? And it is overall very encouraging to see something like this. And I couldn't agree more. Like, it is so important to be putting comments in from, every stakeholder, from every stakeholder's perspective, because even though there's an emphasis on patient access, there will be this is an opportunity for those who have concerns about it to be weighing in about things that they think are needed, but that might pose obstacles, right? So it's all the perspectives need to come in. Doesn't mean you can't go from RFI directly to final rule. There still would be a proposed rule opportunity, but it is a kind of fresh, not exactly restart, but we're looking at this with fresh eyes, i.e. new administration, and tell us how we can spend the next 4 years making advances and making adjustments.
And I think it really is fresh eyes, right? It's an important opportunity for all stakeholders, as you say, to get their perspective, into the discussion, because you can't assume that the people who will be making the next rule have been involved in the prior rules. I think there's a lot of new thinking coming in. And I think they really are taking the cards and throwing them up and seeing how they fall. And it behooves all of us to make sure that we clarify the good things that exist and that we've been working on, so that some of them might stick.
As a fire girly, someone who really likes fire in production, because I've had experience with both implementing older standards, connecting to HIEs, national networks, everything that would be what I consider legacy technology that you would see in TEFCA. In fire world, whether you're talking about the fire IG in TEFCA or the open developer APIs, I think this is how I would respond. So number one, what I want to see out of this new administration with this is that fire APIs work okay, but they're never going to fulfill what they could do unless we kind of rethink how they get to production. So a big part of that is the testing, certification process. I would really, really strongly urge this administration to look at how they certified technology. So there's a conversation about this online. People are talking about this, but instead of certifying the components of the larger technology stack for the EHRA solutions or other solutions that get certification, start certifying on the actual APIs. A big problem that I had in connecting to APIs for both a consumer workflow or of a business workflow, the backend services APIs I was talking about, is that a lot of people certified to the G10 update, which would have given you access to those fire APIs, but they don't work in production for a number of reasons. So they work in test environments, but a lot of them don't work in production because, one, maybe customers didn't adopt the technology. This is where CMS can incentivize providers. Or two, they haven't had a lot of people use them, so they're kind of clunky. I would like to see moving to certifying the APIs, because if we start saying the APIs are production ready, then they're actually usable for a lot of use cases beyond just patient access. They're going to be used for enterprise purposes, and it's the foundation you need for the Fire IG in TEFCA, because I do not believe that the Fire APIs can work in a TEFCA without working in the open developer ecosystem, because they need to get ironed out there. So I would respond a lot with the certification of APIs as a new way forward after high tech, because the certification program came out of high tech, and that's a long, long time ago.
Indeed, and there certainly are. There is a discussion around the certification program. We'll probably be able to focus more specifically on that aspect as well as we go along here. Oh, sorry,
Dave. I mean,
it ties to the information blocking element, because if the APIs don't work, that's when all the information blocking comes into play. Like a big thing in this, over the past 4 years was a lot of developers would complain to ONC about, hey, this doesn't work, I'm not getting access. And ONC is like, well, that's not under our purview. That's going to fall under other agencies to investigate, like OIG and other things of that sort. So there was this gray area that existed. And ONC said, all we can really control is the technology portion. So if we're talking about the technology portion, that really falls under this RFI. And then you think about there were the patient access APIs for the both providers and payers, and a lot of commentary around that was the rollout of that was not aligned. They didn't have the same compliance dates. So like the payers started making their APIs available in the summer of 21. And honestly, they did a better job, but they left a gap because it was only for mandated lines of business under CMS and not commercial lines. So a lot of what this RFI could move forward is like production ready fire APIs that is supported both from the EHR vendors and from the payers and their underlying fire server companies. And then making sure that those APIs will work at scale for consumer use cases like patient access, like for apps like OneRecord, Apple, Common Health, FlexPA, everybody else I'm forgetting, but you all exist. And then making sure that those could be reused for enterprise purposes, because that to me is the holy grail of the Fire APIs. It's not just for consumer access. You can build business to business applications using those Fire APIs to pull data. And it's a lot less expensive to use FHIR APIs to build those kinds of exchanges than a lot of the older traditional IHE-based stuff, just because it was so specialized and so hard for people to get up and going with.
Yeah, and Stephen, I know you wanted to. Oh, sorry. Go. What was that, Jen?
Specialized from a technology perspective. That's what I meant.
Yeah, I think the point that you were just raising there about the business to business, the non-consumer aspects of FHIR exchange. One of the impressions that I took away from the RFI was that it almost overemphasized the patient aspects to the detriment of the business to business aspect. Now, we, as this group all knows, the patient aspect needs some love for sure. But I did want to, as we are preparing to make our comments, I think one thing that we will talk about is, yes, absolutely, do the patient side, but don't forget about the business to business aspect as well. And as you were saying, the two do go together. If you have the one, it helps with the other as well.
Yeah, because so just for our audience listening, what we're talking about is the difference between these APIs is the authentication method. Like, how do you authenticate? Are you a patient, or you a provider, or you're another computer system, right? The API is still the same. And then the data that comes through is the same. So for me, a lot of the reasons why you were able to use those APIs over the past 4 years was the patient access use case. If you went to an EHR vendor and said, I want a client ID and secret to access this API, they had to, under Cures Act, with no special effort, give you that API to build consumer-facing applications. Those APIs are available for other use cases. I've been building applications for B2B purposes beyond my consumer app for the past 2 years, and I'm seeing them work at scale successfully, but they don't work universally across all of the EHR vendors who have certified to the G10 update. So this goes back to my point about certification at the API level. That will allow the use of these APIs for beyond just consumer apps and consumers getting their data and everything that is near and true to my heart. It's actually going to allow for payer, from provider to payer data exchange. It's going to allow for other types of edge use cases that we're not really thinking about, or even provider to provider data exchange for pure treatment purposes, not just payment and operations, which I just started with. So I think it's very important that you get these FHIR APIs right. What I notice is a lot of EHR developers, they kind of, they just did the checkbox under Cures Act. Let's move beyond the checkbox.
Stephen, you've been waiting very patiently.
No, it's fine. It was really just a follow-on, because what I've seen in the discussion about this, about certifying the APIs, is it's being presented by some commentators as an either or. Like, why bother certifying the EHR? Just certify the APIs. And in my mind, having been through, EHR certification since the inception, I think it's brought a lot of value. It's sort of slowly and progressively raised the floor. So I'm interested to see what all of you think about that. Does the EHR certification need to go away for us to move ahead with API certification, or can we have an overlap and be more thoughtful about that?
Well, I think certifying the components, because not all the components are necessarily used, because when I say G10, I'm referencing to the specific certification criteria that exposes the FHIR APIs for anyone listening. So there's things before that, G9, G8, and these are different components, tooling within the EHR that
capabilities.
So they need to be working because they're part of how care operations happens today. I think the pushback is probably going to be, I don't actually think there should be pushback. I don't see why you can't just layer it on top. It's like, you're already certifying to the components. Let's now just certify those APIs. So it's like only building out the G10 certification. Honestly, that's it. Certifying the APIs is just saying we want to go a step further in what we were doing for certification, and we're focusing on the G10 part of certification to make sure that what you're certifying to is works in production, as opposed to just a test environment for your checkbox. I think this also really, the two certifying bodies, I kind of think they dropped the ball in the past couple of years on making sure their clients were pushing out things that were ready for production. And that's where you get a lot of the initial information blocking complaints. I mean, I like to CC those bodies on every email that I send to EHR vendors to tell them what's wrong with their APIs. They don't answer, but I
Didn't we
CC.
also change the nature of how certification happens so that it's a little bit more of a self-certifying process with a check by those groups that doesn't necessarily happen in all cases? Aren't we also talking about sort of strengthening how certification happens in ways that's a little more hands-on, or am I wrong about that? Yeah.
I don't know as much about it, but I do think certification is needing a facelift.
Yeah.
It needs a Kris Jenner. Just kidding. You can edit that out.
I'll leave that to the editor's discretion. But I mean, I think that it is there is an interesting conversation that's obviously occurring more broadly when you're able to be thoughtful and get away from some of the more emotionally charged political rhetoric on both sides. There is an interesting question about deregulation and at what point do we not necessarily just deregulate for the sake of deregulating, but at what point does it make sense to take a look at existing programs and say, okay, hang on a second, let's give this a facelift, as you put it, Jen. And it does seem to me. Oh, sorry, what was that?
Right sizing. I mean, we've learned so much. Let's when we're throwing the cards up in the air, let's make sure we rebuild the house correctly.
Yeah, and to me, getting rid of the EHR certification program entirely would be a major error. That there definitely does need to be a backstop there as far as what EHR vendors are reasonably expected to provide. But can that be focused more on interoperability and less on particular specific checkboxes within the clinical operation workflows that are being supported? How necessary is it to be very prescriptive about what the EHR must provide from an operational perspective, as opposed to obviously core concepts of making sure that you can capture the clinical data that's necessary, but then focusing on the interoperability aspects does seem like a reasonable path to me, if that's the direction we go.
I think that because this is a combined RFI with, we were trying to speculate, why is it ASTP/ONC plus CMS? It sounds like a math equation. Is that so if you think about certification right now, what I noticed, I've spent a lot of time on the website that hosts all the organizations that are certified and to which components they've certified. There's a lot of EHR vendors who they have customers who use certified technology and not certified technology. So when I would go to request access to those EHRs and then their downstream clients, they'd be like, okay, here are the clients and here are their FHIR URLs. But all these clients aren't available because they don't actually use our certified technology. They might just use an EHR, the same EHR components, but they're not using a certified license. Does that make sense? I just want everybody to nod their heads if they're understanding what I'm saying. Dave, you know what I'm talking about? Mm-hmm. Okay. So what I always found frustrating by that was it's really, and I'd be like, well, why aren't these providers adopting your certified technology? And they're like, they're not participating in any programs, payment programs and incentives. So they really just need it to run their business. So I think this is where CMS comes in. How do you get more and more providers to be adopting FHIR APIs? And I think this is where the CMS side comes in, thinking about incentives and programs for at least providers that do get reimbursed by anything under CMS. I think it ties together the payer-patient access APIs. And those payer-patient access APIs also could have more enterprise or B2B use cases in the future. So what I'm trying to say in sum is that I think it's an opportunity not just to rethink certification, but also incentives to get a higher adoption of FHIR APIs by providers purchasing their EHR vendors' license of those APIs.
Indeed. And I think there's been historically some hesitation on the part of CMS to bring anything even sort of on the spectrum approaching a nuclear option with respect to making too much of a hard requirement on the providers. There has been, I think, an attempt to rely on EHR certification to a degree, and then the expectation that you use a certified EHR. And yes, there are interoperability expectations of providers as well. But I think there is definitely more that CMS could do to just be very clear about what the expectation is for any provider that gets reimbursement, exactly as you were saying.
Yeah,
I think that's one of the elephants in the zoo here is, if CMS really leans in to requiring interoperability, all they have to do is say, we're only going to pay you if you have these capabilities, right? If you, whatever it is, if you bill us using, such and such a methodology or tools, if you exchange data, I mean, CMS has always been the biggest lever to pull to incentivize provider adoption. And that's the beauty of the idea of bringing those two agencies closer together.
Providers have to. This is Deven's specialty, so we have the expert. Providers have to release records. That is their job. That is their obligations under HIPAA. That is, what Deven's been doing forever with releasing from the medical records department. And right now, the medical records departments have a lot of mechanisms to release data. They outsource those services to ROI vendors. The requesters have other third parties that help request. It's an administrative burden. We're going back to the paper record. How does records leave a clinical system and go to the requesters? FHIR APIs is a really good mechanism for this. So I think that there are a lot of ways to incentivize providers to adopt that technology. The thing that shocks me about the providers not adopting the certified APIs, it's not the providers of the largest EHRs, like the top two big boys. It's really when you start going downstream, to my point about they use non-certified technology. But what's crazy to me is that the fee structure isn't that big. It's not that expensive. So I've noticed anything from maybe a yearly $2,500 fee. I haven't seen transaction fees. I've seen mostly just yearly fees. And they did put into Cures Act the ability to charge for anything that isn't patient access. So I think they could maybe look at that, or incentive programs around that, or something to figure out how to bridge the gap of the fees that EHR vendors are allowed to charge versus the hesitation of providers to pay for them and use them because they don't see value. And a lot of times they equate it to the failure of patient portals. That's what providers have told me. They're like, patient portals did not have the adoption rate. Why am I going to expose data through an API when I already have the portal? There's a cost, blah, blah, blah. I hate my EHR vendor. I think that's where they need to spend time digging in to figure out how to craft a new opportunity to actually get the adoption so that these APIs can be used beyond just what they're mandated for, but actually commercial purposes.
Yeah.
I'm killing it today.
You are. I mean, I actually wholeheartedly agree with that, because I think I know, at least I thought initially, that we could use the information blocking rules and the threat of enforcement as a lever to get the providers to adopt technology and use it in a way that would make all of this work better. And the reality is, who knows if we'll ever get enforcement of the information blocking rules against anybody. And particularly for providers where the penalties are only able to essentially be assessed against somebody who's part of an incentive program. And even there, whether CMS is ever going to really feel like they want to deploy that is, providers are pretty strapped, many of them, around, sort of having time and money to make this work. What sort of package could we pull together that would bring in the right incentives, the right guidance, the right support, and the technology that freaking works? Is a very intriguing path.
Yeah, for me, so for the audience, I had an app that used the patient access APIs, and I sold it almost 3 years ago. And post-acquisition, I started building applications that use the FHIR APIs, but in a business-to-business relationship where there's a BAA in place. And what's amazing to me about these APIs in production is they don't disturb clinical operations because they're connecting to a FHIR server. It's not connecting to anything that can be disruptive. And I think that's important. And I don't think a lot of providers understand that. So when they're wanting to innovate within their practices, or they're wanting to build new applications, or how do we automate check-in or payments or anything of that sort? Like, this is a really, really good way. This is what the internet's built on. We should be embracing this. But providers, unlike Dr. Lane here, are not technologists. So for them to crisscross their brain to understand the opportunity of this investment to actually providing care, it's secondary in how they're thinking about stuff. I think that and I'm not even sure that people in the last administration, or maybe in this administration, are going to have that kind of technical understanding of how to use this in production, the actual implementation of it. I would call for this administration and in this RFI to really embrace FHIR as the underlying standard and figure it out, that the incentives to get providers to adopt the technology across certified and non-certified products. And I also think that's on the payer side too. This is my preaching to the choir. For employers and commercial plans, like, let's get that data flowing. That is very important. It's all that financial data that is valuable for how we receive care, and healthcare in the United States is too expensive.
Jen, we're almost 45 minutes into this discussion and no one has mentioned AI, but I will, because what has providers really excited right now is AI. AI to improve their workflows, to reduce their burden, and maybe eventually to help them practice better medicine. APIs, to my way, I mean, you accuse me of being a technologist, but I don't consider myself. But APIs provide a set of tools, glue and duct tape and ribbons to tie together innovative tools with their operational workflows within what we call an EHR. I mean, it seems to me if we could somehow start exploring and looking at the opportunities to use APIs as a way to hook in AI tools, as opposed to having to sort of embed them in the EHR, which is proving to be really clunky and really vendor dependent how that goes. If everybody, here's this amazing AI tool and everybody could just hook into it with an API, that I think would get providers very excited.
Well, since you want me to talk about AI, so that we weren't doing the AI podcast anymore, but I'll go into it. There's conversations out there about AI agents. And a lot of people are looking to use AI agents to build integrations. So traditionally, for the audience, there's multiple ways to integrate. You could integrate at a database level. You can connect through an HIE. You connect through a proprietary API, national network. You can just web scrape. A lot of people who are frustrated with the fact that the FHIR APIs aren't production ready or can't support all use cases or all commercial opportunities are starting to evaluate implementing AI agents to kind of be that plumbing opportunity. I haven't played with it yet. I haven't built anything yet. I probably want to and will, but it's frustrating to me that we've also come full circle. When I first started building OneRecord, my first approach was web scraping. And then I didn't think that would scale. So I looked to interoperability to solve my technical problems. And I was so full. Dave knows this. I went all in. I was like, we are going to build this consumer app. We are going to free the data, give it to the consumers. And it was very hard to scale. We couldn't get the kind of coverage that fulfilled that promise of getting all your data in one place. Could somebody start building an application that uses AI agents to then start pulling data for these use cases that providers or anybody else will be interested in? Yeah, but I haven't seen any companies yet be successful. This is just conversations. And I think that's very telling of rulemaking. I'm going to get off my soapbox in a second, but the speed at which technology evolves is not the speed at which rulemaking happens. So now we have an outdated rule, Cures Act. This RFI is here. And it, like Deven said, it builds upon. So there's an opportunity to say, okay, we need to move forward what came out of Cures Act so that it meets the pace of the technology environment that we're in today.
Yeah, I mean, I think there absolutely is a role for AI agents. It's an important one. There's a role for AI on a few different fronts. One, as a co-pilot, if you will, where the AI is sitting side by side with a user, whether that's a clinician, an administrative user, and is providing better insights, better suggestions and prompts. And then there's the agent construct where the AI is acting more independently. And obviously they both are appropriate for different use cases. I think we're not quite at a point where folks are quite ready, I think, for an AI agent to be diagnosing and prescribing, for example. But scheduling an appointment, trying to make a prior authorization. Yeah, all of those things make a lot of sense. I do think that there are some challenges that we'll see if we try to use AI agents to replace integrations. That may work in some very specific use cases, but I think the integrations are going to be necessary for the AI agents to do their job. Is what I think we'll find in most of these cases.
But I like, Jen, your point about using the AI agents to build the integrations. I mean, you hear all the time about using AI agents to write code, but like, why not? Building integrations is slow and expensive and frustrating.
Yeah, and it's not even just the integrations. I always like to think of fire like a tree, because like the trunk is the API, and then all the branches are all the different resources. And like, you have to know which resources to call for and which ones have correlations to one another. And a developer needs to build that into their API. And I think a lot of people new to health IT and new to fire, they might not necessarily understand all those relationships. So like an agent could potentially, I'm making things up right now, nobody believe me what I'm about to say, in my mind, because AI is smarter than me, is going to be able to figure out all the things. I actually have this idea. I want to build a large language model that takes everything from like HL7 and Zulip and all the work groups and everything on LinkedIn and everything in Twitter, and then like every podcast and everything with all these health IT people and interops that we know, and then put it into an LLM that can help new developers, because I think then they can build faster, better products. But I don't know how to build that. So that's in my next phase of life.
Fair enough. There's something that we were kind of touching around a little bit that we got to around in the provider adoption of EHR's conversation, and that did strike me out of the RFI also was, in some cases there was explicit references to wanting to ensure patient choice. There were even some references, I think, to supporting provider independence. If those weren't directly in there, it was definitely an implication that I took from it. And more broadly, what I envisioned as being an undercurrent was this desire to ensure that there was a functional economic marketplace between consumers of healthcare and providers of healthcare. And now I'm definitely starting to get into inference here, so I could be wrong. But my sense was wanting to put a little bit of brakes on the centralization of healthcare and the limiting of choices for consumers due to consolidation. Am I out on an island there, or was that a sense that others got as well from the RFI? Stephen, I'll call on you, because
I don't think I would have I wouldn't have articulated it as clearly as you do, but in retrospect, yes, I think you're right. I think there is sort of an old-timey notion in there And as a provider, I mean, again, as you guys know, I've worked in large systems my whole career. But that's not the whole story of American healthcare, and I think for us to meet the needs of, rural folks and, folks across the spectrum of needs, we need to have a diverse healthcare ecosystem. And if we can support that, through our little world in health IT, that will be good. So that I will make a point of focusing on that in my comments.
Well, and you said something interesting there in passing, but I picked up on it and wanted to pin you down on it a little bit more. You referred to an old timey notion. Can you elaborate on what you mean there?
Well, again, I think and certainly this has come up a lot in the work we've been doing in California. There's the haves and the have-nots in the clinical world. There are those who have technology, who have, high-end major EHRs and have been enjoying the benefits of that. And then there's those who don't, who are in small practices, who are in, low resource settings, who, may be of an age or in a community where the technology has not, really come to the fore. And they are being left behind, and they are providing a different sort of care. And that's not great. I mean, you call it equity, call it whatever you want, but I mean, I think there is a diversity that needs to be supported. And old timey was the notion of the solo doc in their practice in some little town somewhere. They still exist. There are a lot of little towns that have either one doc or no docs. They might have an NP or a PA or somebody who comes through town. And we don't want them selling snake oil in that little town. We want them providing state-of-the-art care. And the technology is what will allow that to happen.
Well, and I think you touched on an interesting point there around the technology, and again, I'm definitely inferring and interpreting here, but a sense that I got was a frustration that why should a physician feel like they can't make it in independent practice or in a small group practice? That why should I be forced to join a large health system in order to actually get technology that works and integration that works? That feels like it should be a solvable problem. So again, I'm definitely inferring and interpreting, and I mean no disrespect at all or imply that the larger health systems are a bad thing. But I think to the extent that there becomes one or two large health systems that completely dominate a large geographical area, my sense is that that's the sort of dynamic that they're trying to maybe fight against.
I would love that. I want the old-timey docs back.
I'd like the old-timey prices back.
We would all like the old-timey prices back in a lot of different ways. But want to be respectful of our time here, Stephen. I know that you actually have patients to see. So I really enjoyed the conversation as always. I look forward to continuing it. I think we ended up hitting on a lot of the topics that we had talked about covering, but there certainly is more to cover here. And there will, I'm sure, be more that emerges over time that we can talk about in our next episode. But for now, thanks, everyone. I appreciate your contributions as always. And thanks for listening.